So, under normal circumstances, Professor Salents would welcome you or open our conference, but he's in Sydney, hasn't been well, and we're really grateful that you have been able to join us today, both of you. So he was instrumental in establishing the first working party to write guidelines for the training in clinical genetics in Australia. He gained his doctorate in genetic disorders of the skeleton, including osteogenesis imperfecta, in 1979. With Dr. Jenny Salents, specialist in children's rehabilitation and working with specialists in children's physiotherapy and occupational therapists at the Children's Hospital at Westmead, he developed a comprehensive multidisciplinary program for the skeletal investigation and medical treatment of children with OI. My tongue needs a rest after that. That was a bit of a tongue twister. I think you'll all agree that Dr. Salents is the go-to medical specialist for anything OI related. He studied at the University of Sydney and having studied at the University of Sydney and University of Melbourne, he has gone on to educate international doctors, including Dr. Lainey Alcorson, who opened our conference today. Away from OI, what interests Professor Salents? We're learning about the behind-the-scenes little bits and pieces about people. With a long interest in classical music, he tried to combine the study of music at the Conservatorium of Sydney, now that is absolutely huge in itself, when he was a medical student. Now, nothing like taking on, a mammoth task. However, medicine won out because it wasn't so easy to do both. But music and his religious faith are what sustains him. So please welcome Professor Daivd Salents.
Oh, we can hear go.
Now, are you going to talk to us or are we doing a Q&A? How would you like to run this?
Well, my understanding is you're going to do a Q&A, but I do just want to make some preliminary comments, particularly to say several things. Well, thank you for inviting me to speak to the National Conference again, and it's nice to see some familiar faces and some new faces, and it's really, really important that you continue to grow, because your advocacy and your support for the people with OI in Australia is absolutely essential. Can you hear me, Gail?
Sorry, yes I can. I'm just having a mini conversation on the side with Mandy, who's going to run around with the microphone, so I'm sorry to disappear.
Okay.
Yeah.
Can the audience hear?
Yes, the audio is fantastic. I'm getting the thumbs up from the back of the room.
Okay, that's good. So I prepared a small handout of 6 pages, which I asked John if this could be distributed to people.
It has.
But if they don't have it, we can send it to everybody digitally. So
no, that's all been printed and everybody's waving a copy at me right now.
Yes.
So John follows instructions.
Yes, one of the important things about what I've written is that it really does now take or need a partnership between multiple different aspects of the healthcare professions to deliver comprehensive care for people with OI. And people with OI need to insist on having that multidisciplinary care, and we can no longer ignore what was ignored in 1975, that osteogenesis imperfecta is a whole range of various disorders of differing severities, different symptomatology, some very special syndromes, and I mentioned OI with donut lesions in the skull, and people will wonder about these, but we've seen all of these through our clinic. When I started to withdraw from the clinic in 2012, I'd seen 530 families in New South Wales alone, and the Victorian study was 190 families. Now, people say, where were all those people? Well, some of them were babies who were very severe and did not survive in the long term, and some of them are dear friends who've passed on already. So, over the period of 50 years, we've seen a vast range in Australia of all the different types of OI. And what happened in the last 2 years was the expert committee on bone disorders in the world, which I sit on, and I chair the osteogenesis imperfecta and brittle bone group in that big group, because there were 760 disorders affecting the bone in the last naming of all the different disorders. The technical word is nosology, but it just means naming and classification. It turned out to be that there are at least 24 numbered types of OI. Now, they changed all the numbers, so if you keep putting the type of OI you have with a Roman numeral, that's not the Solent's type. They're supposed to be Arabic numerals. But we also want people to know their mutation, and we no longer talk about mutations. We talk about variations, genomic variations in genes. And those genes are all in a database called Online Mendelian Inheritance in Man.
Take a breath.
The states are variable in their support for doing people's mutation, and many adults complain to me that they can't convince the state to do their mutation. I think that is sad, because I think today more than ever, people need to know their specific underlying type of brittle bone disorder, because we are now talking about precision therapy. In other words, using the correct treatment for each type of, OI. And as, the numbers grow, we're finding it's far more complex. The other theme, of course, is the importance of having a clinical genetic consultation. And we keep finding surprises, like people who have 2 separate OI mutations. That's called digenic inheritance. And it's really, really important that those people are identified and they can have family studies, in other words, their mums and dads, to see whether mum has one of those variants and dad has the other one, or whether they have both variants from one parent. So increasingly, that's a feature. Another feature is that we have far more of these X-linked families or sex-linked families, particularly a gene called PLS3, and they're just not being referred to the specialists, and the specialists are not understanding. And so we really have to push that young women who are the children of affected boys or men, know that, they may get osteoporosis in their late teens, early 20s, certainly during or after pregnancy or premenopausal osteoporosis. So these were the general themes that I've mentioned in that, and every little section has some gems in it for people.
So what you're basically distilling that down to is it's good bedtime reading. Is that correct?
Well, no, it's relevant reading.
Absolutely.
It's at your meeting, and it's worth going through and saying, yeah, look, I have OI type 1. So somebody mentioned they thought they had either OI type 1 or 2. Type 2 is a very sad group of disorders that are perinatal. They're all very sick baby. They may have hundreds of fractures. So there's nobody sitting there who has OI type 2. But OI type 1 has several different collagen genes and several other genes that lead to brittle bones. And there's a lot of variability in OI type 1. The other fiction is that the numbers are not about severity grades necessarily, but about groups of disorders that look alike and that have similar problems. So they're not a severity grading, and that's a mistake that keeps getting repeated by the people who don't understand or don't ever read the original papers. So it makes me cross sometimes.
Yeah, I'm not surprised, but you know, this is making it very obvious why research needs to be done, why statistics need to be gathered and whatever, so that you can build up, as you say, a multidisciplinary team of managing multi-disorders. Yeah.
And they read the literature. Yeah.
Yeah, exactly. Yeah,
So you've got to be advocates for yourself and well informed and know about this. And I will try and write some more things for, you know, when the website is up for the person, the ordinary person to use as, you know, this is more about, you know, what it is from a personal experience, although I. Now, I do want to mention one thing before people ask questions, though, and that is eventually this year, the results of the research studies that were done at the conference 4 years ago and 2 years ago have now been published by Verity Pacey and Marie Cousins, and their collaborators. And that was all to do with two big studies. One was muscle strength, and the other one was to do with bone geometry, and that was mainly done by Marie with this specific group of people from Belgium. But it's actually, they're wonderful papers. I will ask Verity when she's less busy if we could have some lay précis, lay summary for the ordinary human being, including me, because it's very sophisticated work on muscle strength, and I really thank people for collaborating in all those biceps things and muscle strength testing. Some of the young, or not young people, some of the people coming to conference did, but it's now published. Yeah. So,
it's fantastic. It's always encouraging when you find out that things that you've been part of the research program does actually come to fruition. So that's great.
Yes, absolutely published. Yep. And my review, you know, this year is worth reading if you really can read that complexity, because I recapitulate the history, and you know, we have done so much research. It is incredible the contribution that this Australian group have made. And while there's a lot of trumpet blowing from the OI Foundation in America, OIFE, that's the European consortium which we're members of, and our own group have really contributed beyond our small numbers relatively.
It's fantastic.
So we are thanking every one of the people who have been at the conferences and who have let David and I into your lives for your contributions, because without you, it would not have happened.
That's wonderful, isn't it? Give yourselves a round of applause for being part of that fabulous research.
For you guys.
Yeah. So are we ready for some Q&A? And if we are you okay if Lainey comes up and helps with answering any questions, joins in there?
Yes, absolutely.
Yes? Okay, well, I might disappear for a little while and leave it to you three to manage what's going on. Thank you. Now, Lainey's going to come up. So if you stand by the microphone. Okay, do we have any questions? Yeah, sure. If you're able to come to the front, that would be great, because then you'll go on the video.
Can you see me? Okay. Hi, Dr. Slens, first of all. My mom sends her regrets that she couldn't be here, Patricia. But I just wanted to ask some questions about switching permigerates. So
Excuse me, please, Can you speak more slowly?
Oh,
we're having trouble.
Yes, of course. So I wanted to ask some questions about the biphosphonates.
Can you just go back a little bit from the microphone, because I think it's reverberating. If you just kind of go back about where Rex is. Or go and stand at the podium.
Okay.
Yeah, because the two microphones are not happy with each other.
Oh, okay, that makes sense. Okay, does this work better?
Yep.
Yep. Okay, so I have been on disodium permethrinate since I was 3 years old, and recently a lot of doctors and endocrinologists have wanted me to switch to the zoldronate permethrinate, the biphosphonate, and I have been very nervous about that, and I was wondering like what to expect if I were to switch to that. Would my bone density go lower? Would I be more fragile for that period? Would I have adverse side effects? What was your opinion on that?
So zoledronate's 800 times more potent than permethrinate.
Yes, they have told me that. But what would I have to expect? Would I be more fragile?
Zoledronate and its various combinations stay in your skeleton, possibly for life. So there is always the risk that taking too much of it can lead to low bone turnover repair. So increase your risk of stress fractures. And that we've seen in a number of members of the society. So naturally, I'm very cautious. Lani has thought a lot about this, Dr. Alcarson, and there is obviously benefits in little children.
Yeah.
The problem has become the difficulty of obtaining, particularly IV permethrinate. On the other hand, I'm not sure quite what you have.
Oh no. Oh.
We've lost them.
Can you even hear us?
I can't quite hear you.
There we go.
Speak into the microphone, don't speak
Yes.
to me.
I have type 4 OI.
You have type 4 OI?
Yes, type 4.
And do you know which of the genes in type 4 OI you have?
I'm not too sure, Dad. No, we're not sure.
You're not sure, yes.
No.
Yeah, some people have variants in the type 1 collagen genes. They're straightforward. I suspect, looking just at you, I'm not your physician, that you would probably benefit from either monthly oral risedronate if you tolerated it, rather than an intravenous preparation.
Yeah.
And I would only just maintain your bone density. Professor Gunton at Westmead, you can hear me okay, can you?
Yep.
Who spoke at our meeting, is quite conservative, and on the whole, she would just monitor your bone density, and as long as it was staying maintained from every 2 years, she would not necessarily want to give you more bisphosphonate as an adult.
Yeah.
In other words, most of you young people manage without top-ups. So you could save your intravenous Zometa, despite its attractiveness as a once-a-year or twice-a-year drug infusion. It is so potent that you can become overdosed with it, if you get what I mean.
Yes. Right now I've been getting 60 milligrams permethrinate infusions every 3 months, and that has definitely, it helps a lot with bone pain. I do get very big side effects of fatigue and aching, so I'm worried of, since it is more potent, that those side effects will also be more exacerbated if I switch to a different type of biphosphonate as well.
Elfie, I can actually...
Thank you. It's a difficult decision.
Yeah.
I know mine.
Your insight has been very helpful, though. Thank you.
But I do assure you that oral risedronate or Actonel, particularly the type called Actonel, turned out to be quite effective at maintaining bone density if you need to maintain bone density. Now, bone pain is a far more complex matter. but gentle exercise regularly also reduces your pain. So,
Well, thank you so much for that. Very helpful.
Elfie, while you're there, I can just
Yes.
expand on that because I have swapped from
Yes.
one to the Zeledronate. Like Prof said, the frequency of it will extend because of how potent it is. So I haven't actually had a second dose in 6 years.
Oh my goodness.
And I'm at the point now where I have an annual blood test. So what they can do to monitor it is you can have an annual blood test which levels it's called cross-lapse. So it monitors how fast your bones are turning over. And I have that annually and it always comes back. Your bone turnover is really, really low. You can't have another dose. But my DEXA scan is telling me the opposite. So my legs and my arms and stuff are fine, but my spine is -3. So it's osteoporosis.
Yeah.
But because I can't have a bisphosphonate, I have to move to the opposite family of drugs, which instead of building bones, kind of removes bones, or the other way around. It's a different family. But maybe Prof can answer this. The side effects of the other family really put me off. It was more around, it appeared to me like it was given to elderly osteoporosis patients because of the side effects. They were quite, it was brain cancer and heart disease. So it was quite significant to change to the other family of drugs. Yeah. So firstly, for your own experience, like from my experience for you, it's definitely worth it. The pain relief was amazing. I hadn't felt that good in a very long time. But I'm at the point now where I can't go any further with it. So that's something to consider and weigh up and speak to the doctor about.
Yeah.
But yeah, maybe Prof can talk about the other family of drugs because we don't probably know as a group know a lot about the other.
Yeah, I've tried to ask around and it's a little difficult, especially since everyone reacts differently to each biphosphonates and stuff. So
yeah, and I'm sure probably most people in the room are on a bisphosphonate rather than, I can't exactly remember the name. Maybe Jenny and Prof. Is it? Sorry.
Teriparatide?
Yeah. But maybe Lainey could expand on that for us.
yes, thank you so much.
Yes. Prof, they are asking if, can you explain more about teriparatide, rankle inhibitor medication, the other types of drugs that are now being used for adult OI. So, like I mentioned in my talk earlier, Prof, that we do not use teriparatide in the Philippines as of yet. It's expensive, but there are other considerations, like you said, bone cancer and some cardiovascular problems. So, Prof, can you talk more about teriparatide, please?
Yeah, well, teriparatide is a very valuable medicine, particularly for people with OI type 1. It was actually researched quite extensively, and when you look, people, particularly with OI type 3 and type 3-4, which is really a spectrum of people with collagen abnormalities that doesn't work as well. In fact, it's probably a waste of money. It can't be used under 16 years of age until the bones are mature. And secondly, it's limited to 18 months use. So, in other words, it's not recommended beyond. So what I call a rescue medication if, like me, you've been in bed for 2 weeks in intensive care and you've lost some bone density from whatever illness you've had, and it repairs it, quite well and quickly. It really is quite effective. But type 1 OI and all the variations of type 1 OI.
Thank you so much for that. Thank
So
you.
I don't think it's a medicine for young people. It's in reserve if you ever break your femur and you're laid up for a month or two. So.
Well, thank you so much for that. Thank you.
Thank you, Prof. Are there other questions for Prof and Jenny? Yes.
Yes. Hi, Prof. It's great to see you. It's nice to have the expert on OI typologies. I wanted to ask about the PLS3 X-linked disorders, which is what I have. People often ask about which OI type do you have, and I don't really have an answer for that because it doesn't fit within the known 1, 2, 3, 4 set of types. So what do I answer?
Excuse me. We're still having trouble hearing through the roving mic, and we wanted to make an offer which can be refused. That if somebody in the audience needs or wants a private conversation with Prof, tomorrow morning they can ring my phone number, which John and Amanda will give you.
But it's not private. Matthew's asking a general question.
No. But if somebody who needs more information than we can hear, then that offer is there.
Just repeat, if you repeat your question, Matthew.
The general question is, for those of us with the X-linked disorder, in my case the PLS3 gene mutation, what type number should I say to people when they ask me what type do I have?
Well, it's not typed, Matthew. It's not OI type 1 to 24. It was identified originally. There was a study of genes that altered bone density, and then Fleur van Dijk, who had completed her PhD on OI, Fleur became involved and said, well, I have a number of families with PLS3 variants. Of course, quite a number of the people who were identified were women with either pregnancy-related or postmenopausal osteoporosis, and the boys were a bit neglected. And it's really interesting that I went back and I must have, after I finished my doctorate, I published it, and there's an addendum of another 100 and something, or 150 patients that I'd seen in North America, including a really big X-linked family. And so this came from a number of women and these were a series of boy cousins transmitted through the mothers, because that's X-linked inheritance. Now there's a lovely guide that Phyllis Sri-Ganeshan had given me from Genetics Australia about X-linked inheritance, and it's worth reading. But the really important thing to me, from my 40 to 50 years experience, is that people recognise that all the daughters of affected boys who often go out and play football and have 6 fractures in the first 10 years of their life rather than the average 2, I know that all their daughters will be subsequent carriers. In other words, their grandsons, if they have grandsons, have a 1 in 2 risk of those mums passing on that bone fragility disorder to them. And it's completely neglected by the endocrinologist. And it's interesting, it's mentioned in my doctorate, but there's a politic even in the research field, and it's not given a number. It's called a separate disorder, and it's among those 18 to 20 other disorders, as well as OI type 1 to 24. It's or Silence OI type. Well, Silence OI type 5 up to type 5, and then OI type 1 to 24 in OMIM. And don't go there because the politics of genome naming is beyond me. So but I don't know if I've answered your question, but that's my chief beef at the moment.
To summarise, what I've taken from you is there is no type associated with this.
There's no type.
Right.
No,
okay.
No type, no.
And just
there's no type. but that or the Brooke types, the types with joint contractures.
Just a comment, just based on the previous conversation about drugs. My wife and I have both taken part in a sort of an experiment where we've been doing weightlifting with people who have osteoporosis. And me personally, I found it incredibly beneficial. My bone densities have rocketed up. I've been on the drugs for years and years and had no particular improvement, but doing the weightlifting has been immensely beneficial. So I'm happy to talk to anybody else about that who's interested.
Yeah, no, I think that's important. And these two papers, which I can send to you guys from Verity, this is what they're talking about, is how physical therapy can build your bone density without bisphosphonates.
Thank you.
Hi, Prof. Hi, Jenny. I had a question, probably more so on behalf of the parents of our younger members, with preemptively, hopefully to have a pregnancy at one point, you know, if people were interested in that, females or males that have OI. What's the impact of bisphosphonates for patients that want to have a pregnancy? Is there a time frame that there needs to be ceasing of a bisphosphonate? I was told when Andy and I started the process of planning a family that it was not ideal to have bisphosphonates within the skeleton within a certain time frame. Is that still the same?
Yeah. I guess that was a profession, a medical profession, safety margin equals we don't know. We just don't know. But Professor Munns, who's now in Brisbane, did do a study. We aren't aware of any specific issues related to bisphosphonates. But remember that they do slow bone turnover, and babies get their whole skeleton from their mums from the last 13 weeks of pregnancy. So the baby has to be able to mobilise mum's skeleton, enough calcium to build their skeleton in 13 weeks, in the last 13 weeks of pregnancy. So
Thank you.
Good to be off for a year if you can.
Yes, I remember when, I'm still getting over the newborn phase, so my memory's not so great, but I remember it being at least 5 years to be offered, so that might have changed, but you're thinking more so a 12-month period would be at least ideal.
So, yes, yeah, anything recent to conception, preferably, yes.
Thank you.
Of course, as I said, you know, to our first questioner, the problem is with Zometa is that the companies have voted to, you know, to obsolete the old, less challenging medicines, but never less effective, and gone for a drug, Zometa, that lasts, you know, forever and is 800 times more potent. So if you really don't need Zometa before you've had your babies, then wait till afterwards. Yeah.
Thank you, that's wonderful.
Thank you so much, Professor and Jenny. I'm aware that we've probably taken enough time from a man who has been unwell. So if you're okay with this, we might thank you for your time and sign off now. And if any people have any further questions, Lainey might be able to answer them. Is that okay with you?
And yes, and Jenny has opened the possibility that if there was some really burning question, if they contact her tomorrow.
Yeah, on my mobile phone number, because David's one drops out too much.
Right.
John's got mine, John Ryman's got mine.
That's fine.
If they contact me tomorrow morning, before you folk all wrap up. But we wish you the very, very best for the rest of the conference. Have a ball.
Thank you so much.
Thank you.
Okay. Thank you. Okay. As they say in the movies, over and out.
You take us out because you've got the technology.
Okay. I'll have a look at this. Actually, John's onto it. Okay. Sorry.
Sorry.
So do we have any further questions about this topic? Because Lainey's here. She's the expert along with the prof. Just a minute.
Oh, sorry. No. I thought you want to go somewhere else. Oh, I thought you meant. I had more of a comment from Katie's question about the pregnancy. I think I was actually still on Actinol while I was pregnant, and I had a fall and fractured my femur. And when they did the X-ray, I had osteoporosis only in my femur. So I found that very interesting. They never told me that at the time. Well, they told me it was due to the pregnancy, but I didn't understand until Prof just said that it's that last few weeks where they really suck the energy out of your body. So, for the younger people that are thinking about families, we also have the IVF lady tomorrow as well. So we'll be able to talk a lot about the younger kids looking at having families in the future anyway.
Thank you. Yeah, it's interesting. My background's in teeth, and what happens in the first 3 months of pregnancy can severely affect what happens to your teeth. So it's really important what drugs you take, what you drink, and all those sorts of things.
Just a comment on that. I am expecting, and I can't take bisphosphonates, of course. So I'm actually still weightlifting, believe it or not. So it's all good, all safe if you started weightlifting before the pregnancy. But yeah, that's how I've been keeping up the bone density in that 12-month or time that, you can't take any drugs, and so far so good. So yeah, can recommend it even in pregnancy.
Thank you for that. So you're double weightlifting. You're weightlifting weights plus the little bundle. Yes. Excellent.
I just had a question because I'm the first one in my family to ever have OI. Does the types carry across? Most people I've talked to have the same type within their family. So genetically speaking, it's always going to be the same type? Yes?
So yes, the pathogenic variant, the variant in the gene, will be can be given to the next generation. So definitely the same type of variant, same type of OI. Having said that, there will be some variation in terms of manifestation. I'm sure most of you who have a family history of OI, there might be some variation within members of the family, and that's because there are other genes, and that are other genes that can affect bone density, and of course nutrition, activity. So yes, same OI type, but may have different manifestation.
Hi, you may or may not have something to contribute to this, and I'm only asking, it affects our family, but it's not the only family with OI that it affects, and certainly a family who was not able to make it today has a question about the crossover between OI and Ehlers-Danlos syndrome, and where that line is drawn, and whether it is worth testing for Ehlers-Danlos syndrome when it's indicated. Certainly in our family, it's very important that we know that, and we do know that because of genetic testing, but I understand that that's not always the case with Ehlers-Danlos syndrome. And one of our families in Queensland is having an enormous amount of difficulty in getting testing, and they think that that's important for their child because it's not just OI that's affecting her.
So since OI and EDS are both connective tissue disorders, so they may have some overlapping manifestations. So yes, so I think Prof earlier said that it's getting more and more important to have genetic testing done, because then you know what you have. And then there are times wherein you get two different types of connective tissue disorder. He was talking about diagenic, and of course I've read the paper. So I was required to know that. He's talking about having two kinds of variations in the gene. So then that may be one may contribute to the manifestation of the other. So yes, so more and more for those who can afford it, genetic testing is really something that we encourage that one should do. Also, Prof was talking about precision medicine a while ago. So there are medicine that would not work on a certain type. And in my population, we have been giving bisphosphonate to all types of OI, but there are types that I believe bisphosphonate is not really helping. Not as much as in OI type 1 and 3 and 4. But yeah, genetic testing actually is something that we need to consider. Hopefully, it's something that most of us can afford or can have access to. I'm not as good as Prof in answering this, so okay, I'll answer.
I actually think you underestimate your skills. You know, having to stand in, you know, when you've got a professor, an emeritus professor, who's the guru, you're doing an awesome job, Lainey. Any more questions?
It's not a question for you, actually. Where do you see the future with OI? What's possible in the next few years? Gene editing, or how far are we, basically? Is there going to be a cure? I mean, this is a question I used to ask my parents.
So, what I know... So this is theoretical. So from readings, it's not something that is applicable to our part of the world still. So there's CRISPR. I'm sure you're reading about gene therapy. So that's the possibility. Right now, the use of gene therapy is quite successful in the hematology, so thalassemia, blood condition, but not as successful in other genetic condition. But we're moving towards that direction. If it can be done right now in one condition, then the possibility is there, yes. So there's also some aspect of having better understanding of the inheritance pattern. I think that will modify what we're going to see in the future. Like of course, the genetic counseling would provide information to the inheritance pattern, and having informed reproductive decision would probably change eventually the scope on the what we're seeing right now. You're getting my drift. Thank you.
How are we going with questions?
Just to get back to CRISPR, I'm sure we all know the name CRISPR and all of that. Will this editing, if you see for the future, will this be done in a fetus, in a adult, or in a child? Is this where we see this going, or what do you see the future of this kind of editing being?
So you know about PGT, right? So pre-implantation or prenatal genetic testing for a certain condition is possible nowadays. Even for us in the Philippines, if you can afford it, you can have genetic testing of your for IVF, embryo. So it's more of choosing which embryo to implant if one has this certain condition. So that's one mode that is available right now. But if you're asking if it's going to be in the fetuses, probably not. There will be some ethical issues that we need to sort out.
Actually, what I'm asking is, I do know that, for instance, you can use IVF, and when my first child was on the way, we went to see a geneticist, but at the time, I'm from South Africa, the testing would have taken about 3 months to America, 3 months back, and by that time it would have been useless, so we decided not to bother and to just go ahead, and, the dice fell where they did. But anyway, I'm thinking of CRISPR in the future, just hypothetical. Will this be done can I have a CRISPR done on my genes, or would it be, can it be done in adults, or would it be like an operation on a fetus, or what do you see the future being?
I'll give you an example for a certain rare condition. So SMA, it's spinal muscular atrophy. So right now you can give one injection in a newborn who has SMA, and that newborn will be cured, just one infusion. So that's how we're seeing things right now. So that's a different condition. So yes, that's how gene therapy is being done right now. So I said earlier, beta thalassemia is, there's great stride in that condition, and now SMA. So we don't know. So newborns, yes. I think that's the way we're going right now.
I'm sorry, just one more thing. So is the real concern that you're releasing this live, basically like a virus, into the population? Is that the issue at the moment? Because you're actually changing genes that's going to be passed on. Is that why CRISPR is not more widely used? And even I think if we think about the incident in China a year or two ago, there was a big backlash when this doctor cured some people with CRISPR. So is that the concern, is letting this into the...
I'm not the...
yeah, no, I understand,
but
just hypothetical.
From my readings, they have been trying. When you say virus, it's not actually the live virus, but just a vehicle for the right gene to get into the body. So you're not talking about virus that you're inputting in one's body. It's just a vector, something that would put the correct gene, or the gene that would work in your body. So there are technical difficulties right now. They haven't been very good at it. We thought by now we would be able to master it, but it's not. We're not seeing it that way. So I don't know what's holding it up, but the technology is not that good as far as I know. But they're working on it.
So it's mostly the fear of the unintended consequences, maybe.
Yes, and of course, before we
how
can
that
use
happens,
it,
right?
we first do no harm, right? So we need to make sure that it's really safe. But it has been successful. That SMA, that's a successful intervention.
Okay, we have time for one last question. I saw your hand first, young lady.